Good morning, everybody. Thank you for letting me come and kick it off at this early hour before I race back to an armed services hearing that I'm going to, but I really appreciate this opportunity to Bobby and Todd and Carl for the kind words. I was last here about a year ago. It was the day before I got asked to join the national ticket, and it was an NVTC event that was really fun. And it was funny because Mark Warner and I were here together, and as we were walking in, Mark grabbed me, and there was a lot of press there. Actually, there was a lot more press for me last year. I don't know why. But Mark grabbed me right before we walked in, and he said, "Now, Tim, if there's any controversial question, you let me answer it. You shouldn't be saying anything controversial today." But that's just a tribute to what a good friend he is, and I'm really happy to be with you. I'm a big NVTC fan and have been since I was lieutenant governor and got outside my own neighborhood of Richmond to work with you guys. You do such good work, and I'm so glad to be here at this first Capitol Health Tech Summit because, boy, do we need your help. And boy, do you have a lot of expertise that you can provide to a nation that's grappling with really important healthcare challenges. When I came to the Senate in 2013, the committee I really wanted to be on was Health, Education, and Labor Pension. And you go to your respective leader and you make your request for committees, and when I asked Harry Reid, "I'd really like to be on Help," he said, "That ain't going to happen." And I waited for an explanation, and I'm still waiting for it. That was 4.5 years ago. I couldn't complain because I got on great committees. I ended up being on Armed Services, Foreign Relations, and Budget, which are wonderful committees for my own interests, wonderful committees for Virginia, but I never gave up the desire to be on the Help Committee. I wanted to be on the Help Committee because 16 years in local and state government, what did I know? As governor, your biggest line item is education, and your second biggest line item is health. As mayor, your biggest line item is education, and your second biggest line item is a variety of safety net programs that would all be in the health umbrella. And so I felt like that's what I really knew, but I didn't get on the committee. Nevertheless, I've worked very hard in my first 4 years in the Senate on issues like career and technical education and workforce training issues that you're passionate about too. And I've tried to be helpful on finding solutions and advocating for legislation that I think would be helpful in healthcare. For example, there is a bill, the Connect for Health Act, which is something that's supported by a lot of our health technology companies. I'm a co-sponsor of it that would expand the use of telehealth and remote patient monitoring within Medicare with the idea of using these in Medicare and then hopefully learning some things and spreading them beyond Medicare. But I got lucky. I came back, and my consolation prize for being on a losing national ticket was Chuck Schumer said to me, "I think we're going to need some help on help." He said, "You've got a higher profile now. We're going to have quite a battle about the next chapter of the Affordable Care Act, and having you on would really be helpful." And so since January, I think it was the 3rd of January, I was added to the Help Committee. On the 5th of January, 3 days after becoming a committee member, I led a group of 15 Democratic senators, and I wrote a letter to our chairman, Lamar Alexander, a really good friend, the Finance Committee Chair, Orrin Hatch, the Senate Republican Majority Leader, Mitch McConnell, and I said, "Look, we're 15 Democrats. There's a lot of talk about do we repeal the Affordable Care Act. We are 15 Democrats. We are ready to sit down with you right now to talk about solutions, improvement, fixes. You can call it a replacement. We'll call it a repair. I don't care what anybody calls it, but there are common sense things like the Connect for Health Act, like negotiated purchase of prescription drugs under Medicare Part D, and other things too that we want to put on the table. And you have ideas you want to put on the table. And what we really need to do is to hear from doctors, patients, small businesses having a hard time buying insurance for their employees, hospitals, insurance companies, pharmaceutical companies. We need to hear from stakeholders about what's working, what's not working, and what they think should be fixed so that we can find the improvements that will let you say you replaced it and let us say we improved it. I have worked since sending that letter, leading that group of 15. I have worked cooperatively with the chair of the Help Committee, Lamar Alexander, to try to find a path forward. And we are right now at a very, very critical decision point. And the decision point is basically this. Do we try to fix the healthcare system with only one party participating and with no hearings from patients, physicians, or do we try to sit down across the table from one another and fix it together? It's 1/6 of the economy. It's the most important expenditure that anybody ever makes in their life, is the expenditure on health. And there is so much that we need to do, but we're right in that decision point in the Senate right now, right now. Let me tell you how it looks. Let me tell you about a bill that I introduced yesterday. Let me make a venture a prediction, but it's kind of a hazy one about what's going to happen. So you all know that what happened first is that the House grappled with, over the course of a couple of months, whether they could find a Republican-only bill that they would pass to repeal and replace Obamacare. And it was difficult. They had repealed it many times, but because of the fact that, okay, now there's not a president that's going to veto this, this is going to be real, it was hard to come up with a proposal, but the House did so by late April. I think actually there was an earlier effort in March that kind of fell apart, and they did so in late April, purely with Republican votes. There were no hearings on the bill that passed, no patients, no doctors, no providers that spoke. They would not allow Democrats to propose amendments, and when the bill was passed, they passed it before there was a CBO score, because they were interested in passing it before they knew how many people would lose health insurance as a result. I think you've seen the news about this. The CBO score eventually came out, and it indicated that under the proposal that was passed out of the House, 23 million Americans would lose health insurance. That's the combined population of about 16 states. And there would be dramatic cuts to Medicaid, dramatic cuts, total cuts of about $1.3 trillion over the next 10 years. Medicaid in Virginia is probably like Medicaid in most states. 60% of Medicaid recipients in Virginia are children. About 15% are our parents and grandparents in nursing homes, and about 18% are people with disabilities. That's who gets Medicaid. Medicaid would be dramatically slashed. The House proposal would significantly weaken the protection that people get under the Affordable Care Act if they have a pre-existing health condition. My family has twice been turned down for insurance for at least one of the members of the family because of pre-existing conditions. And I got to tell you, my family is the healthiest family in the United States. Before that protection was put in place, we were twice turned down, even though the only hospitalizations ever in the history of my family of 5 was for 3 childbirths. But twice we were turned away, at least for one of our family members, because of pre-existing conditions. So the House bill had some significant challenges, had some positive aspects too. But the challenges were the kinds of challenges that, frankly, you run into when you try to do something without a public process, so no surprise. And they're also the kind of thing you run into if you try to do something just with one party participating. This was a common critique that had some validity to it about the Affordable Care Act, because as you know, the Affordable Care Act was passed with 0 Republican votes, with an asterisk by Arlen Specter's name, because he either voted when he was a Republican and switched to Democrat, or switched to Democrat to vote. But essentially, as you know, the Affordable Care Act, when it passed in 2010, passed in a purely partisan way. It was not a purely partisan bill. In the Senate version of the Affordable Care Act, there were 145 Republican amendments that were accepted into the bill. There were nearly 50 hearings just in my committee, the Help Committee alone, and there were 25 days of debate about the Affordable Care Act on the floor of the Senate before it passed. It was a bill that was heavily shaped by Republicans, but there wasn't a single Republican vote. And that's one of the reasons, frankly, while the Affordable Care Act is not near as strong as it could have been, because at the end of the day it was purely partisan. And the way to fix that is not to make it worse by having one party now come up with fixes with no public hearings and no amendments. But the House bill came to the Senate. And the Senate has a norm that we would have no legislation if you can't get 60 votes. That is sadly, the filibuster and cloture rules have kind of been abused, but they are where they are now. And where they are now is you generally can't do legislation in the Senate if you can't find bipartisanship. Neither party has 60. Neither party's going to have 60. And so in the Senate now, as a general matter, you can't do legislation easily without bipartisanship. However, there is a narrow procedure called budget reconciliation under which you can do things with 50 votes plus a tiebreaker from the vice president. You can get 50 and a tiebreaker, you can do it. And the Republicans are trying to write a health care bill in the Senate that would get 50 out of the 52 Republican votes right now. Closed door, no hearings. We haven't had a single hearing on the House bill that's come over. And what we're being told is, as they're grappling with this right now, the idea is to try to find that bill that will get 50 out of 52 and to put it on the floor and just have an up or down vote with no amendments. That's what we're being told. Now, I think I can guarantee, I don't know whether that will work. I don't know whether it'll happen. It's hard to get to 50 because you have some members, Republican members in the Senate, who think the House bill is not conservative enough, should go farther to eliminate Medicaid expansion and do it immediately rather than having a glide path that phases out. But you also have some Republican members of the Senate whose states have accepted Medicaid expansion who don't want to get rid of it. So it's not easy to get 50 out of 52 for a Mother's Day resolution in the Senate, much less something like this. But there is an effort to do it, and we will know by the end of the month whether we're going to pursue on a one-party path or whether we're going to open up the discussion to the public and to the minority. Obviously, we ought to open this up. We should open this up. It is 1/6 of the economy. It is the most important expenditure that anybody makes in their life. And if we're going to do this, let's do it right. Because I think even if there is a one-party version in the Senate, it will look very different than the House bill. Even if the House accepts what the Senate does and it is signed by the President, I can pretty much guarantee if it's done just with one party with no hearings and meaningful public input, that it's not going to really fix the problems. And we'll be sitting down a year from now having a discussion, looking at each other across the table about, okay, what can we do to fix this? So why don't we just do that now? And that was the purpose of the letter that I wrote to the main committee chairs and the majority leader on the 3rd of January. Open up the door and let's have the meaningful discussion right now, and let's each propose the fixes and changes that we suggest, and let's find a path forward. Yesterday, I've introduced a number of bills and co-sponsored a number of bills dealing with discrete improvements to problems with the Affordable Care Act, but health care more generally. And I introduced one yesterday that I timed very specifically to hopefully open the door for conversation. Lamar Alexander, and if some of you might know Lamar, I bet Bobby, you probably know Lamar, really sharp guy who's the Republican chair of the Health Committee. Lamar is not just a U.S. Senator, he was Secretary of Education, he was governor of Tennessee, he was the president of the University of Tennessee, and they had a hospital and a medical school and physician practice groups. He fully understands the human consequences of getting this right or getting it wrong, and he wants to get it right. I'm absolutely convinced Lamar Alexander wants to get it right. About 2 months ago, we sat down and we said, look, there may be a need for the Republicans to try to do this all on their own, but the right thing is if it were to open up for dialogue, what do we think is the most significant problem in healthcare right now? And we both agreed that the most significant, or one of the most significant, because you could cite a couple, one of the most significant is instability in the individual marketplace. If you're trying to buy insurance not through an employer, even if you get the Obamacare subsidy, the marketplace is pretty unstable right now. You have some parts of the country where very few insurers are writing policies. There's been a lot of uncertainty injected into what's going to happen in the last 6 or 8 months, and you have insurers pulling back because of that. And you also have some parts of the country where the individual marketplace, frankly, is really attractive to people who are very sick and have significant needs, but not necessarily so for the young and healthy types. And so from an actuarial standpoint, the prevalence of high-cost individuals is driving premiums up real high. Again, this is not the only challenge in healthcare, but it's one of the most significant challenges, the instability of the individual marketplace. So Lamar and I, 2 months ago, we kind of reached a little accord. And that was, let's each try to write a bill to stabilize the individual marketplace. And our deal was, Tim, you write a bill that Democrats will really like, but don't put any poison pills in it that Republicans will hate. And Lamar said, and I'll write one that Republicans will really like, but I'll try not to put poison pills in it that Democrats will hate. And if the moment ever opens up where we can really have discussion across the table, we'll bring both bills up. And we'll have experts tell us what they like and what they don't like, and then we might be able to find an accommodation or a little bit of this and a little bit of that to fix the marketplace. Yesterday, Tom Carper and I and 3 moderate Democrats introduced a bill to stabilize the individual marketplace, and we did it in a way that Democrats will like, but we did it in a way that Republicans should like. President Bush and the Republican majority Congress grappled with some of the same issues when they wrote Medicare Part D. Under Medicare Part D, seniors have a prescription drug benefit, and there's sort of an average about what seniors might get, but then there's seniors who use a lot of prescription drugs where the costs are very, very high. And that high usage could drive up everybody's costs, or you could figure out a way to kind of backstop and protect states or localities or individuals who have high usage, and so you use reinsurance, which is a very common tool in the insurance industry. You use reinsurance to backstop high claims. And Medicare Part D includes a reinsurance provision where there's a federal backstop for high claims, and that enables the premiums and costs for everybody else to be set at a lower level because people know there will be that backstop there. That was done. It was bipartisan. President Bush was the president when Medicare Part D was done. It got Democratic and Republican votes. Reinsurance was included. It's now worked for 10 years, and it's had the exact effect that it was intended to. The Affordable Care Act had a reinsurance provision for the first 3 years that helped stabilize the individual marketplace that then transitioned and expired. And so what we are proposing is a reinsurance mechanism that has been proven effective and that has had bipartisan support in the past to try to stabilize premiums. And there's other things you could propose, but we introduced it yesterday, and I hand-carried it around on the floor to Republican colleagues, and I've said, look, this is something that y'all have supported in the past, and if you will open up the door and allow for discussions and hearings, I think it's something that could really improve the product. So what the Republicans will do in the Senate in the next 10 days, really, they will make a decision about 2 things. 1, can they reach a consensus of 50? And 2, if they do they just put that bill on the floor for a vote, or do they put it into the 2 committees and allow both the Finance Committee, where Mark Warner sits, that deals with Medicaid and Medicare, and my committee, the Help Committee, do we have hearings, look at the good and the bad, propose amendments to try to improve it and make it better? And obviously, I think opening the door and allowing sunlight into this is the way to fix it. What I have suggested is a fix of a very important piece of the system that needs to be fixed. There are other fixes, and you're going to talk about a lot of opportunities today. Let me tell you, if I look at the healthcare system big picture, what this brain trust here in this room and more broadly in Northern Virginia, what you have to bring to the table, what NVTC has to bring to the table. Here's what we've got to do to make our healthcare system one that we will feel very, very good about. First, we got to start with health, not healthcare. We will not be able to have a healthcare system that can take care of an increasingly unhealthy population with outcomes that we'll be proud of. We just can't. And we have a system that is focused very much on health care. And we get some of the best, we do get the best health care in the world. We have the best institutions. Inova, what a fantastic institution, and educational institutions, and we have the best providers in the world. But we don't have the best outcomes in the world. And we don't have the best outcomes because we focus much, much more on health care and less so on health and wellness. And so that has to be a huge part of our rethinking about health and healthcare going forward, and you can help us do that. Make it about health and wellness first and healthcare second. That's first. Second, we have to, and this is a corollary of number 1, we have to make sure we're paying for the right thing. We are a system that pays for procedures instead of outcomes, and we get the best procedures, and we get an awful lot of them because that's what we pay for. But we don't pay for outcomes, and our outcomes aren't that good. And other nations in their payment models essentially pay for outcomes rather than procedures, and they get a lot better outcomes than we do, even spending significantly less as a portion of GDP. There are other reasons why they spend less than GDP than we do too, but the focus on paying for outcomes rather than paying for procedures is a big part of it. So the migration of, and it has to be a migration. You can't change the payment system like that. People are used to, hospitals used to billing a certain way for certain kinds of procedures, and so you have to get on a meaningful path to evolve to paying for outcomes. And some of that is being done. There were some innovations in the Affordable Care Act that's starting down that path, and we have innovative healthcare providers in OVA also who are embracing that and figuring out how to do it. But that is a huge issue going forward. And then third, the use of technology. And then there will be one more. But the use of technology, this Connect for Health Act around patient monitoring and telehealth, has so many applications. It has applications in rural Virginia. It has applications at VA systems. If a VA hospital doesn't have the subspecialist at every VA hospital, but you can do good telehealth between them, you can really improve the quality of healthcare at the VA. So technology and telehealth, and this Brain Trust has some huge expertise in the area, can be so helpful. And then finally, the whole area of bio and individualized medicine and personalized medicine. It's just exploding as a result of the research that was done into DNA sequencing and the understanding of individuals. And that's part of what the effort that ANOVA and Mason and the institutions here are about. And there are just so many opportunities there to personalize what we do and make it more effective by personalizing it and reduce the downside consequences and adverse reactions by doing it, and you all have a huge part in that as well. NVTC, as I've worked with NVTC over the years, has had this great expertise in information technology, communications technology, but increasingly, as I've worked with you, there's been the growing kind of bio sciences side. Virginia was thought to be really strong in IT and CT, and Maryland was stronger in the biosciences. But with Genelia Farms and other significant actors all across the Commonwealth, we're now building up a real capacity in that. And it's smart for NVTC to grab onto it and try to accelerate it. The last thing I'll say is I'm not a pessimist about this. We have our challenges in healthcare. But a lot of our thank goodness for innovators like you. We also are doing some amazing things in healthcare. My oldest son is getting married 2 weeks from Saturday. And I'm going to tell you something about his wedding. He's 27. All 4 of his grandparents are alive and will be at the wedding. His wife is 29. His fiance is 29. All 4 of her grandparents are alive and will be at the wedding. The junior one of those 4 couples has been married for 60 years. When I got married, Ann and I got married, 2 of our 8 grandparents were alive. 1 was healthy enough to come to the wedding, and 1 couldn't. And that seemed really normal. That was really normal for 1984. And here we are, 2017, and I'm not sure this one is normal even 2017, but the notion that we're living longer because of great advances in everything from immunology to reduction of infant mortality to pharmaceutical innovations, that we're living so much longer, what a thing to celebrate. And yeah, it creates headaches in Medicaid and Medicare, and it creates headaches in the healthcare system, and how do you finance it? But it's good to step back sometimes and realize that our headaches are being created by something really fantastic, which is the power of innovation has given us the ability to live longer with quality of lives, and that all 3 of my kids are in their 20s, and they still have wonderful relationships with all of their grandparents. And I think other families are experiencing that too in a way that they didn't before. That's something to celebrate. And ultimately, what we're celebrating is great innovation. And then we just have to design a system that will keep up with the advances in life expectancy and quality of life that we've been able to achieve. You have a huge part to play in that. And as a member of the HELP Committee, and if Mark were here, he would say the same thing. The way we divide this up in the Senate is HELP takes everything about healthcare except the financing of Medicaid and Medicare. Finance Committee takes that. Mark's on that committee. I'm on health. We want to be your partners. Last thing I'll say, and Bobby, this is for you. One of the 2 things that we hope we're going to do in the HELP Committee in these 2 years, the first one is this, and the second is rewrite the Higher Ed Act, and I've said this to Todd as well. You guys are so focused on workforce needs. If we rewrite the Higher Ed Act by just listening to college presidents, we could do a B or B plus job. But if we talk to people about the workforce of tomorrow, industry, thought leaders about the workforce needs for the next 10 years, because we won't rewrite the Higher Ed Act for another 10 years. If we do that first and then talk to college presidents, we can do a Higher Ed Act that will be great, an A-plus job. And of course, higher ed is directly connected to healthcare, because it's about the training of the healthcare professionals that we will need going forward. So I hope to come back and have a discussion about the workforce issues connected to higher ed, including in this health space. Thanks so much for having me. I know you're going to have a great day. Appreciate it.